strengthening health systems in a complex world.
For joining us for so many of our sessions, and we're thrilled to build on the conversations that have been had before us to really focus on how we can address complex health needs in an interconnected and increasingly financially strained world. You know, we've talked about a number of topics today and the pressures from the environment, NCDs, mental health, and we need to understand that every individual, every human being, and their health needs are complex, and they're complex throughout their lives. And when we start thinking about what's often characterized as last mile delivery, but as someone recently told me, it's actually first mile delivery, which is, I think, an incredibly important framing and distinction and understanding that people come first. And I'd love to talk with both of you about your experience and what insights you could share that are really addressing the complex needs and doing so in a way that are meeting people where they're at and are able to do so throughout their life course. You both have very complementary but yet distinct and differentiated experience, and so I'm thrilled to be able to dive into this topic with both of you. First, I'd like to start with you, Dr. Marte, and just do a little bit of level setting about the landscape. You've done a tremendous amount of work on breast cancer and are researching that and have worked across sub-Saharan Africa in particular. And so I'm curious from your perspective, in light of these increasingly complex health needs, are you seeing a shift in terms of the approach to complex care delivery, or how are you seeing that evolve?
Yeah, I think we are increasingly, so I think historically the global health community has been very focused on infectious diseases, as most of you know, and a lot of the funding had been channeled towards HIV, and so the healthcare infrastructure was really built to improve HIV care delivery, but not really thinking about the complexity of patients as a whole. And so, you know, patients who come with HIV also have issues with diabetes or cardiovascular diseases. But I think when we followed the money, the infrastructure was really built to promote HIV. And I think we've made advances there and people are living longer. And so for me, doing breast cancer research in a global health setting is really reflective of that shift. There's really an epidemiological shift where we are seeing more and more people in low resource settings with diseases that we used to historically think about as diseases of high-income countries. And so I think there is a need to pivot. And I think health systems are realizing that. I think thankfully international organizations are realizing that. So there are huge international campaigns around, you know, breast cancer care along the continuum. So not just thinking about treatment, but how do we prevent, manage, and really follow the patient throughout their diagnostic journey. There are also initiatives around cervical cancer. But the point I want to make is that I think for a long time we've thought about diseases in silos, and there's really a need to actually integrate these healthcare systems. And so the shift that we are seeing now is really a lot of people thinking about how we can leverage the things that work in HIV. So community healthcare workers were a phenomenal intervention implemented during HIV care delivery. Can we leverage that for patient education in cardiovascular disease prevention, but then also screening of breast cancer and cervical cancer patients? And I think if we can really make this change, I think that would be impactful in terms of really meeting the patients where they are. You know, a patient cannot go to an HIV clinic. I mean, there's the time and opportunity cost. And so a patient who has several competing demands cannot go to an HIV clinic and then travel another distance to go to a breast cancer clinic and then travel some. And these are in low resource settings where patients need to take time off work. They have huge healthcare dependency needs of their families. And so I think we are starting to realize that our care really needs to be patient-centered. In order to do that effectively, the money also has to be pooled. And so we can talk a little bit about that. But I think the shift is really thinking about how we can integrate systems to address the complex needs of patients.
Thank you for that. And picking up on that and thinking about how to best meet those complex needs and the resources that are available, which are always limited, how can then we utilize what we do know about those complex needs and utilize data and information that's available from experiences, both qualitative and quantitative data, to inform that care? And so, Dr. Cohen, I'd love to turn to you. When you think about data-informed care that is addressing these complex needs, you're focused very much on AMR. How is that manifesting in your work, and how are you thinking about that utilization to more effectively address these complex needs?
Yeah, I think data is going to be really critical to address antimicrobial resistance. First, we need the data to realize what are the priorities, both in terms of pathogens as well as in terms of diseases and in terms of populations. And what we've seen is that whereas we are beginning to realize where the burden actually is, and we know it's primarily in low and middle income countries, and we know that the burden is growing rapidly. In the next 25 years, we're expecting to see almost an exponential curve of antimicrobial resistant infections and deaths. But I think what we don't know is how to deliver the kind of person-centered care yet. What I will say is we did learn how to do that in HIV, we learned how to do that in TB, and we can take some of those lessons and apply them to AMR. But we're in a fundamentally different space. I think there was like an era between the early 2000s and COVID where there was very kind of vertically focused programmatic care focused on HIV and TB. There were centralized procurement agencies, and there were large donor funds. I think we are in a fundamentally different space right now. We're in a space where, unfortunately, a lot of that kind of official development assistance is not necessarily going towards health, not necessarily going towards disease-specific areas. But at the same time, what we're seeing is strengthening of national and regional systems. And so rather than being in a place where we're going to be reliant on these centralized procurement, centralized donor agencies, we need to look at the regionally strengthened regulatory systems, procurement systems, CDCs that are now evolving, and say, how can we adjust our systems and our approaches to basically come up from there? And the last thing I'd say is not only is data important in terms of defining the priorities, which medicines are the most important to research, which medicines are the most or diagnostics are the most important to focus on for access, but even at the clinician level, and Yehuda and I are both clinicians, it's really important to have data. And in antimicrobial resistance, even if you can't have the individual diagnosis of the given patient, and that's kind of the gold standard, if you can know kind of what to expect and make a good prediction based on what the local hospital epidemiology is, you can make a pretty good guess as to what this patient might have and be able to treat the patient appropriately.
And so, Yehuda, when you hear that, and when you're thinking about these investments that are needed, that are regional or contextually relevant, how are you thinking about that? And I'm curious about how we can support more locally led, contextually relevant, and regional systems, standards, and focus without fragmenting a system. Right, because you were talking about learning lessons and being able to transfer those learnings and apply them elsewhere. And so I think that also relates to funding. And so how do we ensure that we're not then isolating ourselves, and those who do have resources and are able to leverage them more effectively aren't decentralized in a way that undermine those goals?
I think it's complex, but I think there is an opportunity for collaboration. I think, so when I think about cancer care, or just really health system infrastructure in general, we think about countries like Rwanda who invested heavily in their health system building. And so, I mean, I think, in 20 years, they've been able to increase their life expectancy by focusing across the board on preventive health and also on maternal and infant mortality. And so I think there's really a role for governments to actually contextualize the needs of their population based on, again, data. I think, I think there are broad standards for what individual countries should be covering, but I think data should really dictate what their priorities are. I just think it cannot be, I think we are at a point in time where it cannot be very disease focused from a centralized organization. And so, yeah, Rwanda focused on HIV and malaria and other needs as well, but thinking about how you can individually fund this is important. And, you know, we evoke the Abuja Declaration because governments are really supposed to spend 15% of their government spending on healthcare, and that hasn't happened. But I think in countries that have gotten close to that, you can see some of that being translated into increased life expectancy and management of diseases across the board. I don't really think there should be, I don't really think global funding should really be in conflict with having national organizations that are strengthened. I think there's obviously the need for external funding, but I think governments should show that initial commitment by being able to spend a considerable amount of their GDP to really strengthen the infrastructure. And I think you can then layer upon it, non-communicable diseases, AMR, but I think it helps build data systems. It's really patient-focused in that it considers sort of the holistic approach to patient care. And so, yeah.
Yeah. And so if we could dive a little bit deeper into those issues and concepts, what are a few examples of the projects and partnerships that are being mobilized that are in fact demonstrating those principles and having an impact and are part of this movement toward a more direct human-centered approach to care?
Yeah. Maybe I can give a couple of examples. And when you were talking about fragmentation, I was thinking if in this kind of new era where we're really seeing kind of the regional strengthening, and we're also unfortunately seeing a failure of kind of the R&D system to bring forward some of the tools, the medications and diagnostics we need to meet the public health needs globally and especially in low and middle income countries. But I think we can look towards coordination, prioritization, and partnerships. And I think those are kind of through lines through some of the examples I'll give now. So I'll talk about kind of 4 things that are really important. I think in order to be able to talk about what are the most important tools we need, countries need to look at their own epidemiology, look at what are the bare minimum basket of drugs, diagnostics, vaccines, and other tools such as digital health systems that can help them address their epidemiology, and then coordinate what other countries are facing those same needs and same access barriers. And can those countries come together to form harmonized lists of priority medicines and diagnostics to improve their market strength and their ability to actually access these health products? So that would be number 1. Number 2, I would say we really do need to focus on access. And so one of the things that has been really great in the area of HIV and TB is there's been a lot of focus on access to medicines. And there's been very innovative things that have come about, such as voluntary licensing, use of the WHO pre-qualification program to demonstrate quality assurance and streamline regulatory approval. So what can we use now across the board, even beyond HIV and TB? But what do we have to do that's new? So for instance, we might not have a centralized procurement agency that can kind of consolidate markets. But what we can do is bring countries and other procurers together to think strategically about how they can coordinate to make sure they're getting the best prices and the best deals on the tools that they need to treat their patients. And then the last 2 things I will just say is that I think we need to basically prioritize what we're asking different cadres of health workers to do. Yehuda mentioned that community health workers can really help extend health systems. So yes, we need to grow the number of health workers, but we also need to be smart about task shifting and what we're asking different cadres of healthcare workers to do. And I think that's really beyond maternal care, it's beyond TB. We can do this across the board. And the last thing I'll say is we need to grow the pie in terms of financing, both on the domestic as well as the international scale.
Thank you for that and breaking that down as methodically as you did. And so, Yehuda, how would you pick up on that? And when you're thinking about that prioritization and those kinds of partnerships, I'd love to hear how you're thinking about that coalescing, and then also picking up on the point about healthcare workers
and the need to expand the number, but also the capacity and the training of those frontline workers who are able to meet the needs of the patients and those that are coming to them for care. How are you thinking about those?
So I think in oncology, we are thinking about, how do we, so if you think about it, I think historically a lot of less developed countries haven't had the infrastructure built for oncology. And there are also very few training opportunities to train oncologists, pathologists within in-country. I think what we are realizing is that there's a huge gap in staffing and resource needs that cannot be met in the immediate setting. And so we are conceptually thinking about the idea of leapfrogging. Can we harness things like, I know everyone says AI, but can we harness things like telepathology to increase capacity of pathologies in low resource settings? There's also this being leveraged in radiology imaging. Can we leverage teleradiology to expand access? And so I think governments, I'm really focused on I think nationally governments should show that this is a priority. A lot of governments are now aligning their medicines and their disease focus with the WHO essential medicines list. And I think this is where an organization like the WHO EML can offer guidance on what countries should be focusing on. And so, I think newer therapeutics are shiny and exciting, but that's not what we are reaching for. We are saying for patients with very common cancers that are seen in a lot of countries, so cervical cancer, breast cancer, do we have the basic treatments to actually be able to provide comprehensive care to these patients? And I think this is where international organizations can offer some of this guidance. I definitely do think that, thinking about health worker extension is important. And so there are a lot of initiatives thinking about how we can actually not only use community healthcare workers, but primary healthcare workers in local settings to actually screen for cancers and actually pick up cancer diagnosis early. And so thinking about the individual as, migrating through the cancer care continuum. Can we diagnose cancers early so that it's easily treatable and we have more patients being cured? Can we then invest in the resources to actually manage diseases? It's actually easier to manage early stage cancer than it is to manage metastatic cancer. And so I think thinking about this in a more comprehensive way is important.
And the degree to which, by doing so and intervening early and mitigating what could be then cascading health complications, et cetera, not only are addressing the needs of the person, but also minimizing impact on a system, right, that's already stressed and it's already struggling under constrained resources. And so I think all of that is incredibly well taken. And, I think when we talk about the complexity of these health needs and the evolution of them, I think it's easy to get overwhelmed and, worried that there aren't going to be answers that meet these needs. And so to end on a hopeful note, you are both working deep in these issues and also with innovations, both innovations technology-wise, but also in terms of the kinds of partnerships, working with unusual suspects who may not be the ones that we would all think would come to bear, be stakeholders in this. And so I'd love to hear from both of you, what is exciting you about the moment that we're in and where we really need to lean in so we're not just talking about these concepts that are important, but we're actually putting them into practice.
Yeah, so I think one of the things that's most exciting to me is I'm working for an organization called GuardP that is really trying to take this idea of that we're living in a new global health environment and working on antimicrobial resistance, which to me underpins pretty much all of modern medicine. If we can't treat infections, we're not going to be able to do anything else. So we need to figure this out. And I think we're working on one project that, to me, brings a lot of these things together. And it's a project to get access to a medication called cefiderocol to treat drug-resistant infections. But I think it's bigger than that one antibiotic because it basically is demonstrating how we can use licensing, early licensing, to get more manufacturing capabilities, to get a more affordable product, to bring innovations and reduce those manufacturing bottlenecks and support regional and local manufacture for critical products to meet kind of regional health needs. But it goes beyond that. It also is really looking at how a nonprofit drug development partnership like GARD-P can actually begin to build the evidence necessary to use this product appropriately in the populations that need it most, and also to work with clinical trialists and implementation scientists in low and middle income countries to figure out what are the priority questions we need to be answering in order to address AMR more broadly. And last two things, it's also using some of the same market shaping approaches that we've learned about in HIV, but it's saying we're in a fundamentally different space. So what we need to do is bring the different procurement entities, countries together to figure out how can we develop regional approaches to coordinate procurement, to coordinate planning to introduce, to coordinate kind of market shaping approaches so that we can get the product quickly, but get it at an affordable price so that people, including in the public sector, can access it. And then the last thing I think we're doing that's super exciting to me is we're working with implementers and implementation scientists on the ground to really identify how do we take up a new product that is not in a vertical program. AMR is fundamentally throughout all the healthcare systems. And if we can figure this out, how to introduce new antibiotics in a safe and sustainable way, I think in some way we've cracked a little bit of the nut.
I think for me, it's really, so I was interested many years back when I was in medical school. I think a lot of people thought about global health and thought about infectious diseases right away. And I think being in an era where we're having these meetings, and I think the panel before this was really focused on cancer in low and middle income countries, is revolutionary. I really didn't think it would happen this fast. There were a lot of white papers about it. Pharmaceutical companies were a little bit dismissive about how you can really treat cancer patients in poor countries when there are competing healthcare needs. And so I think for me, just being able to see the prioritization of cancer care in low resource settings is amazing. And not just thinking about cancer care delivery, but thinking about clinical trials, and even being able to do clinical trials in these settings was unheard of like a few years ago even. And so I think the fact that there's excitement about that, but not just excitement, the fact that there's understanding that this knowledge is bi-directional. So it's not just impact, it's not just, charity to low resource settings, but the fact that this is bi-directional, really creating generalizable knowledge that is applicable across patients and different demographics is really exciting. I think the second thing I'm also excited about is really the innovation. I think there's been a lot of innovation in this space to think about how we can creatively deliver care in low resource settings. And so, for instance, in Rwanda, there's a platform, a cartridge that was used to test people with multi-drug resistant TB. And now that has been adapted to test for different kinds of molecular forms of breast cancer. And I think that's really exciting because these machines are already in several countries around the world in sub-Saharan Africa. And so if you think about the lack of pathologies and lack of technicians for pathology, I think it's great to think that there are innovative ways in which we can leverage what systems already exist. And I think the last thing is really exciting is seeing the public-private partnerships. So UICC is this huge organization that that convenes a lot of bodies related to cancer care delivery. But it's managed to convene an organization called ADAM that's now trying to improve access to medicines in low resource settings. And it has a lot of members, but more importantly, there are members that are represented from ministries of health, from pharmaceutical companies, from companies that do voluntary licensing, who are able to do a lot of the marketing that really shape the landscape of HIV drugs. And so I think the fact that cancer has brought together several players and is really thinking about innovation in this space is really exciting for me.
Wonderful. Thank you for that and for your focus, your passion, your optimism, and the dedication to this work. It's incredible, and we really appreciate you sharing that with us here today. Dr. Yehuda Marti and Dr. Jennifer Cohn, thank you again.
Thank you.